Traumatic injuries are something that no one can fully prepare for. Should the unexpected happen, we at Solomon Sticks Morewa are prepared to do anything imaginable to speed up your rehabilitation. We do this by maximizing our patients' level of independence and functioning abilities, as well as by educating and training patients and families to support the recovery. We provide high-quality, cost-effective therapy in a serene setting with a focus on achieving concrete, quantifiable results that are ideal for both adult and pediatric physical rehabilitation. Our facilities are revolutionizing patient outcomes through personalized physical therapy programs and maximizing patient progress through our hydrotherapy pool. Our professional team consists of physiotherapists, occupation therapists, and highly competent nursing team with an aim for the best physical rehabilitation results. We are open 7 days a week and ready to welcome you.
Welcome, colleagues. It's a great pleasure to have you with us once more this week as we continue with our weekly webinars where we bring in the different specialists, different healthcare professionals from various disciplines to share with us their thoughts, their knowledge and experience and research outcomes from what they're passionate about this weekly webinars. And we are excited to be bringing you someone different this evening. But before that, we also just want to thank you for always supporting us by attending these webinars on a weekly basis. There are some of you been with us for quite some time now since we started sharing these webinars with you, brought to you by Clinics Health Group. And as usual, we request that when you log in, please make sure that you switch off your videos and you also put yourselves on mute so that we maximize the reception and quality of sound and presentation that we have at these webinars. Also, welcome to all of you who might be new. We know that every time we have a different speaker, there are those who are passionate and interested in the topic under discussion. So we expect that there could be some people who are interested in ear, nose, and throat diseases, and so welcome to all of you. These webinars are CPD accredited and they are streamed live on YouTube. So at any time when you want to go back and watch the video or the presentations or listen to it, you are at liberty to do so. Just like us on YouTube and you'll be able to watch previous recordings of these webinars. And we also request that please make sure that when you log in or you register for the webinars, you provide us with your full details, your name, surname, and your practice number or your registration number, depending on the kind of regulatory body that you are registered with or you trained for as a healthcare professional. We've noticed that the HPCS is quite aggressive in terms of following up on practitioners who have not do not meet the required number of CPD points. So this is an opportunity for you to get your CPD points. But make sure that you get it. If you've got problems in getting your certificates, please let us know, and you can send an inquiry to webinars@clinics.co.za or albila@clinics.co.za. So this evening, we're quite excited to be bringing you to you one of our own, Dr. Ridwaan Essa, who's a ENT specialist or at one of our hospitals, Dr. S.K. Matseki Memorial Hospital. Dr. Ridwaan Essa graduated from the University of the Witwatersrand in 2008. He interned at the Chris Baragwanath Hospital, and he was awarded the Intern of the Year for his ability and commitment and dedication towards his patients. He serviced the Soweto Health clinics for 2 years, where an interest in ENT field was sparked. And so Dr. Essa has a wide range experience in surgery. He worked in the thyroid, the breast, vascular, trauma, pediatric, and general surgical units. He became a senior in the ENT department early in his time when he was a registrar. Understanding the responsibility that entailed, he was involved with training at a very junior junior level in training ENT doctors and medical students. He succeeded and completed his studies in otorhinolaryngology, very difficult word, from the College of Medicine in 2017, and attained an MED examination, examined the histology of tonsillar tissues in HIV. That is his research paper in HIV positive patients in 2018. And his work was published in the Journal of HIV Medicine in 2019. And Dr. Essa obtained various certificates from training courses. He attended and continues to educate himself. He has a passion for endoscopic surgery, be it in the ear or the nose. And his mantra, taken from Mahatma Gandhi, is man becomes great exactly in the degree in which he works for the welfare of his fellow men. And so, gleaning from past experiences and the pandemic that we had, he wants to talk to us this evening on the legacy of COVID-19 on otorhinolaryngology. And so we're excited to have you, Dr. Essa, and we're looking forward to an engaging presentation. And thank you very much. Platform is yours now. Maybe we may have to restart, Dr. Essa, because there was no sound from the beginning. If we just maybe restart.
With a wide variety of symptoms, from those who are asymptomatic, from those symptoms that are life-threatening, specifically interstitial pneumonia. The majority of patients with COVID-19 presented with a dry cough, fever, chills, muscle pain, shortness of breath, sore throat, diarrhea, chest pain, sputum production, and nausea and vomiting. Interestingly, the patients with mild to moderate COVID-19 presented with mainly ENT symptoms, those being nasal obstruction, sore throat, and rhinorrhea. While those patients with more severe disease requiring hospitalization, those patients had a fever, cough, fatigue, vomiting, diarrhea, and lastly, shortness of breath. ENT symptoms were very common in patients infected with COVID-19. The most common symptoms patients had were anosmia and dysgeusia being altered taste. Patients had nasal obstruction, sore throat, runny nose, hearing loss and tinnitus, dizziness and vertigo, dysphonia, and all cavity lesions. Most patients with long COVID persistently had anosmia and dysgeusia. The changes in taste and smell included decreased smell, absent smell, distorted smell, And likewise, the changes in taste included decreased taste, absent taste, and a distorted taste. The physiology of smell is that an odorant is inhaled through the nose. It travels through the nasal cavity. In the nasal cavity, the odorant is directed towards the olfactory cleft. The odorant communicates with the olfactory mucosa. In the olfactory mucosa, we have the olfactory nerves that make contact with the odorant. Impulses are then sent towards the olfactory bulb. In the olfactory bulb, we have the olfactory tract that communicates with the olfactory nerve. Thereafter, the impulses will be sent into the brain, specifically the olfactory cortex. The reasons why people lose their smell is still not certain or not known, but there are theories. The possible mechanism of loss of smell is possibly obstruction of the olfactory cleft. The olfactory cleft contains the olfactory nerves. It possibly due to infection of the supporting cells that surround the olfactory nerve, or possibly due to direct injury to the olfactory nerve and olfactory bulb. Importantly, ACE2 receptors are present in the supporting cells of the olfactory epithelium, but not present in the olfactory nerve. Thankfully, the prognosis of smell is quite good. At 60 days, most patients recover at a rate of 75% to 85%. At 6 months, 95% of patients recover from loss of smell. But this still leaves us with 5% of patients who still have functional anosmia and still have disturbances in flavor and taste. Women were more likely not to recover their sense of taste and smell, and patients who had an initial higher insult also were less likely to recover their sense of smell and taste. So how can we help patients with loss of smell? What can be done? Well, one of the ways to help them is something called olfactory training, which is relatively new. What this is that 4 different odorants, what this does is that we ask the patient to deliberately smell or sniff 4 different odorants, 20 seconds each, at least twice a day. And they need to do this for at least 3 months. The odorants that they smell for 20 seconds are usually rose, eucalyptus, lemon, and cloves. It is thought that by smelling this, they promote regeneration of the olfactory receptor neurons, and they may also help with higher order processing of olfactory information in the brain. So since we don't have all of these smells at home, I usually ask the patients to go buy essential oils, and they come with different variety of flavors and smells. Other ways to treat patients who have loss of smell is with oral or topical corticosteroids. It's been shown that oral corticosteroids appears to improve the sensation of smell in 50% of patients, but has many side effects. While topical corticosteroids may not be as effective as oral, it can be used for a longer duration of time with less side effects. Other ways to treat patients who have loss of smell is by asking them to install smoke detectors or gas detectors, as they would not be able to smell fires and smoke. We also encourage patients to closely monitor their food, as they would not be able to taste expired food. We also ask patients to stop smoking, as this does further damage the olfactory nerves. Lastly, since the sense of smell is an important sensation, having lost the sense of smell may cause the patient loss of anxiety, and we do recommend counseling with psychologists to help them cope with this loss. Other ways to help patients regain their smell is possibly taking in vitamin A. Vitamin A plays an important role in regeneration of nerve tissue, specifically olfactory epithelium. It can be given intranasally. Another way is the intake of vitamin B12, and it's important in the maintenance of central and peripheral nervous system. Lastly, zinc can be given. Deficiency in zinc has been shown to have an association with olfactory dysfunction. Also, it may be given intranasally. One of the newer ways to treat loss of smell in patients is with platelet-rich plasma. There have been studies to show that injecting platelet-rich plasma into the olfactory cleft have improved smell in patients. And there's been quite a few good results, although the studies are still in their infancy. How platelet-rich plasma works is that the platelet contains numerous growth factors, and when these growth factors are released, they assist in peripheral nerve regeneration. We gather platelet-rich plasma by drawing blood from the periphery. We then centrifuge the blood and extract the platelet-rich component after centrifuging. And this platelet-rich plasma is then injected into the olfactory cleft. Usually more than one injection will be required. So it has to be done at least about 3 times at different consultations for results to have a lasting effect. This is a summary of what has been proven effective for patients with loss of smell. As you can see, olfactory training is leading way to improve patient smell, followed by corticosteroids, topical steroids, vitamin A, platelet-rich plasma, and sodium citrate. The rest have not been proven to be as effective. The sensation of taste is divided into taste itself and flavor. So ACE2 receptors have been found in the oral cavity and tongue, but there have been very few cases of patients who just had loss of taste. But the majority of patients do complain of loss of flavor, and flavor is a very complex sensation. It combines sensations from a sensation of taste, it combines the sensation of smell, it combines tactile feel of the food in your mouth, the heat from the food, and also the spiciness of the food. In combining all this complex sensory information, we can then get a complex sensation called flavor. And this is what majority of patients do complain of: loss of flavor, not loss of taste. And if we can improve the patient's smell, we can then improve the patient's flavor. And that's our aim. Other symptoms of COVID-19 is audiological symptoms. Patients with COVID-19 may develop hearing loss. They may develop ear fullness. They may develop arthalgia, tinnitus, and dizziness. And this has been shown by a study by, I hope I pronounced this correctly, Kokoglu et al. And he found in 101 patients with healed COVID, the percentage of them did have ear symptoms. The cause of hearing dysfunction, dizziness, and vertigo, again, is poorly understood. It is thought that COVID-19 is neuroinvasive and may directly affect the nerve. It may be because of the ototoxicity of the drugs we give the patient to treat COVID-19, specifically azithromycin and ribavirin. Hypoxia can also damage the nerves. Direct impairment of the middle ear and inner structures by the nerve, and the exaggerated immune response may all play a part in the patient's dizziness, hearing loss, and vertigo. In terms of hearing loss, conductive hearing loss may be due to a Eustachian tube dysfunction, or maybe due to direct invasion of the middle ear by the virus. There was no strong association between COVID-19 and otitis media. The causes of sensorineural hearing loss in COVID-19 were varied. Luckily, only a minority of patients with COVID-19 had sensorineural hearing loss. A study from Italy found that patients with patients with COVID-19 had a higher loss of hearing than those from the pre-pandemic era. It was also shown that patients with COVID-19 who had tinnitus had worsening tinnitus after COVID-19. There were other studies that showed there were no change in prevalence of sensorineural hearing loss before and after the pandemic. And it's also been shown that even those who had hearing loss with COVID, the symptoms were not permanent, and they did improve after some time. A questionnaire done by Viola et al. Of 185 patients found that 34 patients developed equilibrium disorders, and of the 34, 32 reported dizziness and 2 reported acute vertigo attacks. There have been several studies that shown that vertigo and dizziness could be the core symptom of COVID-19. Dizziness is the sensation of disturbed spatial orientation, while vertigo is a subtype of dizziness, and this is the sensation of movement where there is none. The causes of dizziness is multifactorial. It could be low blood pressure, cardiac arrhythmias, anemia, hypoxia, hypoglycemia, amongst others. Dysphonia has also been attributed to patients with COVID-19. It is a voice impairment, and it occurs in 25% of patients who have acute COVID-19. Females statistically have a high prevalence of the disease, but most of them recover. This is mainly attributed to the immune response and inflammatory response of the infection. The oral cavity can also be affected in patients with COVID-19. It has been reported that patients can develop glossitis, a dry mouth, aphthous lesions, mucositis, but again, most of these were self-limiting. Vaccines have been used to treat COVID-19. There were 4 different ways that COVID-19 vaccines function. It can be a whole virus that is live and attenuated. It can be nucleic acid vaccines, viral vector vaccines, and protein-based vaccines. How the whole virus vaccines work is that they use a weakened or inactivated virus. The nucleic acid vaccines introduce mRNA or DNA into the cells, and these produce antibodies against the spike proteins of SARS-CoV-2. Viral vectors are chemically weakened viruses, and the SARS-CoV-2 antigens are inserted in the chemically weakened virus, and these viruses are then introduced into the patient's body. And then there are protein-based subunits that are based on the spike protein, which are the antigenic fragments of the virus. These are also introduced into the body. So the vaccines that use the adenovirus viral vaccine vector, they incorporate the spike protein gene into the DNA of the patient, is the Oxford AstraZeneca, the Sputnik and Johnson & Johnson, and the vaccine that uses mRNA for production of spike proteins in the host cells are the Pfizer and Moderna. The adverse effects of vaccines are mostly mild and self-limiting. They include pain at the injection site, redness, swelling at the injection site, fever, lymph node inflammation, headaches, body pains, joint pain, fatigue, and also chills. In terms of ENT, patients who've taken vaccines have developed sudden sensorineural hearing loss. They have developed tinnitus, dizziness, vertigo, anosmia, and even Bell's palsy. And it's thought that these are due to the hyperimmune response from the vaccine. These complications are exceptionally rare, and the rates of these diseases before and after vaccines have not increased. Again, this is a slide showing some of the patients who developed complications because of the vaccine. These are very large studies, but very few cases of patients who have developed these complications. As a result, in examining the benefits and harms of a COVID-19 vaccine, it appears that its benefits are far more significant than the risks of the side effects that are still very infrequent. To summarize, COVID-19 has introduced new ways for doctors to treat ENT conditions. There is minimal long-term soliloquy for most conditions, and vaccines are still the best route to avoid complications of COVID-19. Thank you.
Thank you very much, Dr. Essa, for this presentation, taking us back to those, shall I say, good old days, or depending on where you said, the bad old days of COVID-19. But thankfully, we've overcome the scare and what we went through during that scary period of COVID-19. Looking back, and with the experience and what you've just shared now, and the efficacy of the vaccines, and what are we seeing now currently? When you have been said that the vaccines have been quite effective in treating COVID-19 and the sequelae of COVID-19 on ENT cases, and also the effect of vaccines. when we look back and with all the studies that have been made, and we looking forward and anticipating another pandemic, would management that we've had in the same manner that we did during that pandemic.
Hello, everyone. I just want to be certain of the question. Are you asking about what ENT conditions I'm seeing nowadays from the residual symptoms of COVID-19? Hello?
Hi, Dr. Bila, are you still there? Dr. Bila?
I can't hear him.
All right, sorry, Doc, let me just check on him quickly.
Thank you.
Okay, so now, can you hear me?
I can hear you now. Thank you.
Okay, no, so yeah, so I got bumped out and I couldn't hear. So I take it that you've answered that question.
No, I didn't hear the question clearly.
Oh,
Do you
no, I
mind
was
repeating it?
asking. Yeah, no, I was asking, I'll say looking back, what you've shared, thank you very much for what you've shared about COVID-19 and vaccinations and the effects of COVID-19 on ENT diseases. And I mean, just sharing the symptoms and the signs that you picked up and the effect that you were seeing that vaccination has had a good impact. Now I'm saying 2-3 years down the line, when you look back, are we able to say that this is how we should be treating ENT cases once more?
Definitely
The effects.
definitely with vaccines. I've seen much less patients with anosmia compared to prior to the vaccine. There were many patients presenting to me with loss of smell for more than 6 months during the COVID period. At that time, we were treating patients with olfactory training, and we consulted for about 3 months. Most patients recovered, but there were a subset that we could not assist, and we had to give them more behavioral changes and more and possibly psychological possibly referral to a psychologist. Is he gone again? If anyone would like to maybe type some messages, I'm happy to answer any questions.
Sorry, Doc, we seem to have lost Dr. Bill again. Apologies for that.
Yeah, no, so by my Wi-Fi has been problems. I've had to change my, you can hear me now?
I can hear you.
Okay, no, thank you very much. There was a question also in the chat box. I've lost. Yeah, that wanted to. Could there just be a loss of taste and no loss of smell after having had COVID-19? And if so, what treatments would be?
There's very little that we can do with just loss of taste, but the majority it's a majority of patients have loss of flavor. I actually haven't seen a patient during the COVID era who just had loss of taste. It was all because of flavor. And there's very little you can do about that. It's nerve damage. There's very little you can do about it, unfortunately.
Okay.
But if we can get the smell back with olfactory training, then usually the flavor returns. I usually give oral steroids and nasal steroids with olfactory training, and that appears to help most patients.
Okay. There's a comment here by maybe she can, that statement, however, applies to ENT benefits and adverse events. The statement, however, applies to ENT benefits and adverse events, I think, from Ty. I don't know if Ty, you could just unmute yourself and just maybe just explain which statement you're referring to. Ty? I don't know if you can make, are you able to comment on this statement, Dr. Essa?
Which statement?
Yeah, that's what I'm battling, because that statement applies to
okay.
ENT benefits and adverse.
Can you hear me?
Yeah, we can hear you, Ty. Go ahead.
Okay, so I don't want to get into sticky waters here, but I just noticed there was a highly erudite, quantified kind of presentation of research about the sequelae on ENT sequelae, but there wasn't the same around the sequelae of COVID vaccinations. That's the one thing. And the other thing is, I think you need to specify your statement, say that the COVID vaccine has been proven to reduce the long-term effects of COVID in the arena of ENT surgery. I think it's quite important that we be very specific about that, because there are other branches of medicine where the jury is actually out, particularly in cardiology.
I think that's correct. I'm referring more to the ENT symptoms post COVID vaccine.
So you agree with Dr. Schoenberg?
Yes, agreed.
Okay. Okay. There's a question from Ridwaan. For patients with chronic sinusitis who contracted COVID-19, what were the most ENT symptoms seen and complications experienced, and how were these treated?
So we did notice more patients with fungal sinusitis after infection with COVID-19. We had many more patients who had fungal sinusitis. Fungal sinusitis is mainly treated through surgery. That's the only problem. They are mainly treated through surgery, and the diagnosis is made through the CT scan, and is also made intraoperatively when we see what do you call a brown thickened tissue and we as ENTs usually can identify that it looks like a fungal infection when we are in theater.
Okay. No, thank you. And the role of the audiologist or speech and audiologist, have you found that in your interaction, this has been quite helpful in making the diagnosis when you, if there was any problems maybe with the hearing loss from COVID, or was that not much of a problem at that time?
There was very few patients who had sensorineural hearing loss because of COVID-19. Those patients who did have hearing loss were usually bilateral hearing loss. And those are patients who are from ICU. And, in ICU, it could be a number of factors which could have caused their hearing loss. Could have been the antibiotics they were using, hypoxia, could have been, it could have had shock. And, we usually have to confirm our clinical findings, and we usually do get the audiologist involved. And usually they do serial hearing tests, firstly at the onset, and then possibly at 3 months after the onset of the disease, to see if there is recovery of the hearing or there's been no recovery. Unfortunately, if they haven't recovered after 3 months, most of them will require a hearing aid if it is sensorineural hearing loss.
Okay, no, thank you very much. I'm trying to see if there's another question. Yeah, I was thinking, but no. Go ahead, Ms. Mchazo. She's our speech and audiology specialist who is at the hospital.
Good evening, colleagues. Can you hear me?
Yeah, we can hear you.
Thank you. Thanks, Dr. Bila. I know that I am known at Clinic Health Group as Nunu, and I just put in that name, Nongceba Nomonde, for HPCSA purposes. But thank you very much, Dr. Essa, for the presentation. I just wanted to add on to the whole aspect.
She's still in ICU, but she's recovering. She's getting much better, but intubated when she's got the trachea to protect
Hi, Dr. Bila, can you please mute yourself?
Might be to the ward tomorrow. No, I spoke to the husband today because I wanted to go there, but I said maybe it's better
Dr. Bila?
to go and see her when she's discharged from ICU.
Dr. Bila. Okay.
Sorry, you can continue.
Thank you so much. My name is Nunu Mchazo. I'm a speech therapist and audiologist, and I do work with Dr. Essa at Dr. S.K. Matsike Memorial Hospital. I just wanted to add on to the patients that have come to me post or just during and even after the COVID-19 pandemic era. And I must say that I still see some of them. Dr. Essa mentioned that a number of them are the ones that have a sensorineural hearing loss. The ones that most of them are the ones that were admitted in the ICU unit, in the intensive care unit. I have seen patients in my rooms who have not been admitted. They tested positive for COVID-19. They were on treatment, obviously, and never admitted though. And, they were treated as outpatients, some of them by their GPs, most of them actually, or physicians. And they've had sensorineural hearing loss. And we've tested after 6 months, tested after a year, tested even after, 2 years. And the hearing loss has not recovered. And, no family history. They are not on any other chronic medication. And some of them are young people. When I say young, they are in your late 20s, 30s, and before it was known that sensory neural hearing loss, it's known, and in terms of research that you get it age related. A lot of patients that have a sensory neural hearing loss, it's age related, but I have seen a number of patients in their late 20s, early 30s, early 40s. Sensory neural hearing loss, we review after 6 months, we review after a year. Some have come after 2 years. It is permanent. And with the passing of time, it has become progressive. So I'm not even sure as an audiologist, what could be that. And all of them have said we tested positive for COVID-19. So I'm not sure, Dr. Essa, can you maybe comment, or maybe some of the physicians or other medics comment on that? Thank you.
I won't be surprised. I mean, what you see is probably some damage from the virus. When I see them in ICU, it's usually quite obvious. They can't hear at all. So when you see them, I think there's not complete sensory neural hearing loss. There's partial hearing loss, and then with the progress of time, the hearing loss becomes worse. So there has been some studies in Italy that have proven that there is some sensory neural hearing loss with COVID-19, but it wasn't complete hearing loss that I sometimes see in ICU patients. So I do think that your results do make sense.
Yes, thank you, Dr.
Okay.
Essa. Yes, you're right. A lot of them, it's not a profound hearing loss, sensory neural. It's mild, moderate, and obviously, as I've mentioned, with the passing of time, some I've seen just recently, last year, and some early this year, and we can see that, with the passing of time, the sensory neural hearing loss is becoming slowly, progressively worse. But it's not at the severe to profound stage yet. Thank you. I agree with you. Thank you. It is partial hearing loss.
Thank you, Namande, and I apologize, colleagues, for that interruption. And Dr. Mashiko, his comment is that are these adverse events not commonly seen in daily upper respiratory tract infections and lower infections, which are of viral origin? Or during COVID, we saw the same symptoms, but of a severe form of the same disease?
Sorry, I didn't quite get the question. Just give me a second.
Yeah. I was asking the same adverse events that we've been talking about, hearing loss, sensory hearing loss, or even other forms of infection or symptoms that we saw. He says there could be just the same. These are of viral origin from upper respiratory tract infection or lower respiratory tract infections, or they could be just the same form of diseases, but a severe form during COVID.
No, it definitely can occur with other viral diseases. We had the same before COVID-19. We had, one of the reasons patients had some sensory neural hearing loss was thought to be of viral origin, and this was before COVID-19. There are other viral causes, especially from the herpes family. But I think when COVID-19 became more prominent and prevalent and endemic, we saw more causes of these diseases from COVID-19 particularly.
Okay. And Dr. Nancy his question is, COVID-19 pandemic was accompanied by a lot of negative narratives that doctors often divided themselves about the choice of vaccines to recommend. The mRNA vaccines-based vaccines in particular attracted a lot of very negative comments. What do we recommend with confidence now, looking back now for vaccinations of our communities?
You mean which vaccine I would recommend?
Yeah, I mean, the mRNA vaccines attracted a lot of negativity. Can we now confidently say we use those ones, or we've got different opinion about this going forward now with hindsight?
I wouldn't comment on that. I wouldn't.
It's not your space.
Not be the right person.
Okay, thank you. You're just doing ENT search and doing cases, but I think there's still a lot of controversy. I mean, I've seen quite a number of comments and articles and colleagues coming up with what researchers are saying in hindsight, and I think the medical fraternity is still divided on this. And I think someone will say that the jury is still out there. I see there's another last question before we close. Dr. Mohammed Lampert wants to know, are patients who experience COVID-19 taking longer or to recover from normal upper tract infection than before COVID-19? Are we seeing a difference now? Maybe we can even look at if there's any pediatrician now who's amongst us who can comment on this, or a physician, not just pediatrician, anyone, any of the other colleagues. Yeah. You got that question?
Look, from my point of view, I'm a pediatrician is a better person to ask. They probably see these primary infections probably more often than I do. I usually see the complicated and prolonged infections that aren't responding to normal medication. But from my point of view, what I'm seeing is I'm actually not seeing, in terms of upper respiratory, specifically nasal and oral, I'm not seeing it more commonly. I'm not seeing them taking longer to recover. But I have seen many more patients with otitis externa, especially with fungal otitis externa. That has really become much more prevalent than the previous years, especially when I first started. I'm seeing much more fungal otitis externa this year than I've ever seen previously. And confirmed on pus swabs, confirmed.
So that could just rhyme with what Dr. Mashiro was saying. When his question was, how common are ENT symptoms in long COVID? So you're saying that you do have case of long COVID in ENT setting?
More otitis externa. More otitis externa with fungal infection.
Is it?
I'm not sure about call that long COVID.
No, yeah. Okay, no, thank you very much. I don't know if there's anyone else, colleagues, who still has a question to ask Dr. Essa. It's not often that we get an ENT surgeon talking to us, but we're glad that you were able to join us this evening. Okay, I think in the absence of further questions, we just want to take this opportunity, Dr. Essa, to thank you for taking your time to talk to us about the long-term effect of what we've seen in ENT coming from the COVID infections. And we hope that as we go forward, that we won't be having this, cases, as you said, that you've seen cases of patients coming back with loss of hearing, loss of sensation, and loss of taste. What I also love when you talk about loss of taste and loss of flavor, it's two different things that you're helping patients to deal with. And also the forms of how to do tests for smell using various mechanisms and ointments that people can use. It's something that we can always be practicing ourselves. And so just want to thank you for this time, and we hope that when we call you again in the future, you'll be available to talk to us about other ENT diseases, outside of COVID. I think there's a lot more that we can discuss on ENT cases. Also to thank the colleagues who joined us this evening for your time and your patience in every times when we call you to join us for these webinars. And we trust that you'll be joining us again next week when we continue. Next week, we're going to nursing, and we hope that we'll get more nurses joining us as we deal with ethical questions around healthcare given by the nurses and other colleagues in the health sector. And also to thank Kamo and Anza for helping us with the logistics and preparing these webinars on a weekly basis, and Toko, and also the clinic secretary for allowing us this platform to share knowledge at this platform. So just want to thank you, colleagues, and have a good evening. Thanks all.
Thank you.